We appreciate you being here, and we will call the meeting to order. And Dr. Curran, if you will please call roll for me.
Thank you, Chairman Mercer. Cindy Mercer, Dr. Mercer.
Here.
Dr. Chi.
Present.
Dr. White.
Present.
Dr. Shin.
Present.
General Carter.
Present.
Dr. Williams.
Present.
Mr. Howard.
Here.
Dr.
Rodriguez.
Toomey is present, that doesn't matter. Dr. Rodriguez isn't present.
Thank you so much. We have some housekeeping issues. Today, we're going to elect our new board officers for 2019-2020. So if I could have a motion, please, that we open the floor for nominations. All in favor?
Aye.
We're going to have the whole slate of chair, vice chair, and secretary nominations. Then we'll close the nominations, we'll vote. So now the floor is open for nominations for chair.
I'd like to nominate Dr. Curran for chair.
Dr. Curran, any other nominations? Thank you. Nominations for vice chair? I'd like to nominate John Halpert, please. Any other nominations? Nominations for secretary?
I'd like to nominate Dr. Rodriguez, since he's not here.
That's great, that is good. Any other nominations? May we have a motion that the nominations be closed?
So moved.
All in favor? So all in favor of this slate of office with Dr. Curran, Mr. Halpert, and Dr. Rodriguez, please signify by saying aye.
Aye.
We have our slate of officers for you, Dr. Toomey. Thank you. Now, we have been distributed the minutes, and do we have any questions, corrections on the minutes that were provided?
I move to be accepted.
Second? And all in favor?
Aye.
Thank you. Dr. Toomey, would you like to give us an update? Thank you.
Thank you so much. I really appreciate it, Madam Chair. And congratulations to our new board officers. I also want to congratulate Dr. Curran and Dr. Rodriguez on his reappointment by Governor Kemp. And I also want to just take a minute to introduce our new appointees to the board, who I've been derelict of duty and not formally introducing. And so if I could just take a minute, let me just first introduce Major General Carden. Major General Carden was appointed by Governor Kemp as the 3rd Adjutant General of the Georgia Department of Defense. He's responsible for directing, coordinating, organizing, and stationing the Army and the Air National Guards of the state of Georgia, the Georgia State Defense Force, and federal and state civilians, ensuring their readiness to perform state and national missions. He's held a number of key positions in the Army and the Georgia Army National Guard, and he was serving in Southeast Romania, among other places recently. I think one of the most important things to say about General Carden is that we work closely with the National Guard in all of our preparedness efforts. We sat together already on the Homeland Security Task Force, and I think you don't think about public health as sitting side by side with the National Guard and planning and preparedness, and yet it's part of what we do. And having you on the board allows that collaboration to be even stronger. So I really welcome you and thank you for being here.
Thank you very much.
I also wanted to formally welcome Dr. White. We met Dr. White last month, but I was derelict of duty in not having her bio in front of me when I introduced you. Dr. White's an attending general surgeon with Piedmont Healthcare in Conyers. He's a member of the Piedmont Clinic. Licensed as a Georgia physician since 2014, with additional licenses in New York and New Jersey, and I really love this. Dr. White was named a New Jersey top doc in 2013, so I think that's, we're grateful that Dr. White came to Georgia and has joined us on the board as a top doc. Dr. White has earned a bachelor's degree in biomedical engineering from Johns Hopkins and a medical degree from Rutgers, completed general surgery at Georgetown, and additional surgery and oncology training at Memorial Sloan Kettering Cancer Center in New York City. Dr. White is certified with the American Board of Surgery and has been a fellow of the American College of Surgeons since 2010. Dr. White is also a member of the American Society of Breast Surgeons and the Society of Surgical Oncology, and resides in McDonough. So I'm really grateful I had the opportunity to spend a few minutes talking to Dr. White about public health and engaging with her about the programs that we have. And I'm really, it's been a real pleasure meeting you and having the chance to, and looking forward to having a chance to further work with you.
Thank you.
And our newest member of the board is Dr. Ryan Shin. Dr. Shin is the Physician Program Director of Health Services Research and Academic Affairs at Kaiser Permanente, Georgia. He serves as the content expert in both human subjects research and health services research, and serves as a liaison between research, quality tech, EMR systems, and operations from a logical and content owner perspective. He leads academic affairs and partnering with regional medical schools, and has been leading efforts to foster medical student rotations and student research, which I think will be of particular interest in many on the board who serve in academic institutions. A board-certified orthopedic surgeon specializing in shoulder surgery. He's also certified in sports medicine, orthopedics subspecialty, a fellow with the American Academy of Orthopedic Surgeons. He received his medical degree and completed orthopedic surgery at Boston University, and then completed his fellowship at Brigham and Women's Hospital, one I know well, part of the Harvard Medical School complex. And he serves on many committees at Kaiser and many leadership positions, and I think particularly your interest in research and how we can partner with Kaiser, particularly looking as we are exploring opportunities for access to care within public health, I think will be particularly timely for your appointment. So I really appreciate you being here, and great to meet you today. Thank you. It's been, how do they say, it's been quite a week in Lake Wobegon. Well, it's been quite a week, quite a month in public health, and we've had many, been very, very busy. You've heard about several of the outbreaks, and you'll be hearing further about the outbreaks that we've been dealing with that have taken up many of our time. And some of them will be having presentations today, but others we will continue to update you as time goes on. We completed our closeout, which was part of our important operations, and have been having monthly in-person health directors meetings. And I'm letting you know that because many of you are familiar with the health directors, many of you know them personally, and I think this has been really helpful. Before, as important, I think, as telehealth is, I think for us particularly as we're beginning some of the challenges that we've had in some of our areas, I think it's been really wonderful to have face-to-face meetings and begin to build those relationships, and we've been doing that on a monthly basis either here or in Macon, and that has gone very well, and we'll be continuing that through the end of the year. I completed finally the program reviews. It only took me about 3 months longer than I thought it would, but the program reviews have been very enlightening about what the scope and depth of what we do, and what some of the opportunities we have for enhancing our work, particularly to identify areas of concern. And one of the areas that was identified to me was informatics. I was very familiar with the informatics work that Dave Ross had done at the Task Force for Global Health, and Dave has been a good partner for us, and you may know him through some of your work. But I didn't realize that public health had a unit that was doing that and doing work in parallel, in fact, with what the task force was doing. And I asked Carl to present today to let you know. And so I too am looking forward to that presentation. So thank you very much for the
Good afternoon, Madam Chair, members of the board, Commissioner Toomey. It's a great pleasure to be with you this afternoon. And I'd like to take a few minutes to talk to you about an ongoing outbreak investigation. We actually have recently documented our largest ever Legionnaire's disease outbreak in Georgia associated with a hotel in Atlanta. So let me tell you a little bit about this outbreak and where we are with it and where we're going with it. Before we start, I know that we've talked a little bit in here before about Legionella, but just to get everybody on the same page, I wanted to give a little bit of background about the Legionella organism. It's a gram-negative bacterium that is found naturally in warm water sources. So it is found naturally in areas of the plumbing system like hot tubs, showers, fountains, wherever the water can be warm enough that this organism can survive and actually grow. It grows and survives well actually in biofilms in plumbing systems as well. So if there's some organic material in the plumbing system that allows the organism to essentially attach to the pipes themselves and essentially grow in this biofilm. Persons actually get infected with Legionella when they breathe in droplets of water from these systems that essentially are contaminated with the organism and then get aerosolized. So people breathe in these droplets of water containing Legionella organisms, and it usually takes between 1 and 14 days for individuals to show signs of illness after they breathe in these contaminated water droplets. Legionella infections indeed can be very, very severe. If we look at Legionella data nationally and in Georgia, people that get sick with Legionnaire's disease or with Legionella infections, actually almost well over 90% of them are hospitalized with pneumonia, and about half of them actually can end up in the ICU. About 10% or so of cases usually result in death. So again, this can be very severe and a very significant infection. The very first Legionella outbreak was actually recognized here in the US in 1976, associated with an American Legion convention in Philadelphia at a hotel as well, and that's where the name itself comes from. So individuals that belong to the American Legion are called Legionnaires, and that's how the disease got its name. If we look, even though that was the very first and actually one of the largest Legionella outbreaks ever documented, we recently, both nationally and in Georgia, we've been seeing that Legionella cases and outbreaks are definitely on the rise. They've been increasing over the last 10 years or so. So let's take a look at our data in Georgia. So this is the last decade of our, again, Legionella cases. It's a reportable disease in Georgia, so we receive reports from hospitals and labs and healthcare providers about Legionella cases. So as of last year, 2018, our number of Legionella cases that we documented here in Georgia actually quadrupled from 2008. So from 43 cases to 189 cases. And again, if we just take a snapshot of our cases last year, very consistent with what I said before, 97% of our case patients were hospitalized, half of them in the ICU, 8% of our cases were fatal, and the mean age of our case patients were about 60 years, about 60% of them were male. About a third of our cases of Legionella, again, were actually acquired in healthcare settings, and that's pretty consistent with the national picture as well. So what about our outbreaks? That also have been on the rise as well, especially last year. In 2017. In 2017, we actually had 14 Legionella outbreaks that we investigated. In 2018, we had 7. Some of these outbreaks actually extend from one year to the next, so they sometimes can bleed over into the following year. And for us in Georgia, our outbreaks most commonly occur in hospital settings and also in hotel settings. And no matter whether it's a hospital or a hotel, most of our outbreaks are associated with the potable water plumbing system. And again, that's very consistent in these very complex plumbing systems. Another thing that we see in most Legionella outbreaks is that there's usually some sort of precipitating event that sort of changes the character of the plumbing system in some way, whether it might be some construction or a water main break, or some sort of a water temperature or pH fluctuation that either allows, again, these organisms to proliferate and grow if the temperature gets warm enough, or if the disinfectant level gets low enough, or if the water stagnates in some way where it's not moving through the plumbing system. These organisms can attach to that biofilm. And so very often when we see Legionella outbreaks, there is a precipitating event like that, and then the picture that we really see that it presents to us is pretty characteristic. It almost looks like sporadic cases of Legionella over a period of months. So we might see a single case that was associated perhaps with a healthcare facility or a hotel, and then maybe 2 months later you get another one, and then maybe a month later you get a third. And that indeed is an outbreak, but it's again represents sort of sporadic risk of these organisms, again, sort of breaking off in the biofilm and potentially being aerosolized and inhaled by people. What's really key about Legionella outbreaks, no matter where they occur, when they occur, is that almost every single one of them were preventable with a more effective, water management system and a more systematic way to take care of the plumbing system in these large facilities. So let's talk about the ongoing Legionnaire's disease outbreak at a hotel in Atlanta. And again, this began in July. On July 12th, which was a Friday, we in DPH epidemiology actually documented 3 laboratory confirmed cases of Legionella infection, again, that were reported to us with a lab confirmation. And it turns out that once we, just the initial information, collecting the initial information about these 3 cases, it turns out that all 3 of them had attended a conference held at the same hotel in downtown Atlanta in late June and early July. So right away, having three individuals with lab confirmation that, again, attended the same conference in the same hotel was clearly an alarm for us that we wanted to look into, indeed, whether and how many other cases may be occurring in this outbreak. The hotel was absolutely fully cooperative, voluntarily closed on Monday, July 15th, while the investigation was proceeding. But what we did, sort of initially, as we do with every outbreak, is really to try to assess and articulate what the goals of this investigation were. The hotel was closed to prevent, sort of any ongoing risk of exposure to other patrons of the hotel facility. But what we wanted to do, again, as we do in a very standardized way, we want to be able to assess the magnitude and scope of this outbreak. So we wanted to find additional cases. Are there more than just these 3? We want to support that case finding with laboratory diagnosis as appropriate. And most importantly, we want to elucidate both the risk factors for individuals to get ill, doing an epidemiologic study, and also elucidate the source of the Legionella in the environment of the facility itself, meaning conducting environmental and water testing of the water distribution system in the facility itself. All of that information to drive, ultimately, remediation and control of the potential risk of Legionella in this facility. These outbreak investigations are notoriously complex. They're tremendously lengthy. They get very scrutinized, and they're very, very expensive. So they're very, very, sort of long-term investigations, if you will. They usually have a very short-term, sort of initial control, followed by a lengthy investigation to ensure that we have it out of the system. So let's talk about what it looked like initially on that very first Friday, because I think this is very telling. It is really very different than what I first described when I was talking about our usual healthcare or hotel outbreaks with the sporadic cases maybe 1 month after another. Right away, when we looked at Friday, July 12th, when we had these 3 laboratory confirmed cases, we also heard about 2 other individuals that actually had symptoms of pneumonia and were hospitalized but didn't have lab confirmation. So we initially considered them to be suspect cases. So there were 5. And here they are, July 2nd, July 3rd, July 4th, July 5th on their onset dates. So very tightly clustered within a period of a week's time. So for me, seeing an epi curve like this, again, is very, very significant because with this tight clustering of cases over a period of days, it really indicates to me that, again, there was potentially what we would call a point source of their infections. I don't have this to be proven yet, lab results not yet. This is the very first day, but I see an epi curve like that, and I'm like, there must be a point source that these individuals were exposed to. And so then, again, it allows us to sort of think about if there is 5 potential Legionella cases spread out over just a few days period of time, we may need to think about doing some very immediate control measures based on this epidemiology. And so when I see something like that, initially when you think about a hotel facility and something that aerosolizes water, whether you look at the usual suspects, and I said, does this hotel have fountains? Does it have a hot tub? Does it have a pool that has jets in it? So is there something in a place in this hotel that might, again, be able to aerosolize water? And indeed, this hotel has a large courtyard that indeed has a hot tub, a pool, and fountains. So again, without any laboratory results or testing, the hotel facility was very receptive to doing this initial immediate control, meaning because it looked to be a point source outbreak epidemiologically, let's not take a chance and let's go ahead and close down the fountain, close down the hot tub, close down the pool right from that first Friday, even before they closed the hotel in its entirety, just to ensure that there was no ongoing risk. So that, again, is sometimes how outbreaks unfold, where you see something significant enough to do an immediate control, and then we work towards gaining additional epi information and additional laboratory information down the road so that we can institute further control measures. So then what did we do? Ultimately, the steps of the Legionella outbreak investigations are pretty standard. The hotel, as I had mentioned, was absolutely fully cooperative. They hired a Legionella contractor, which are experts in Legionella outbreaks. They're plumbing engineers, and they essentially also hired a CDC, what is called a CDC elite laboratory, to do the Legionella testing. These again are experts in these areas, and it's very standard process during a Legionella outbreak investigation. The hotel actually notified by letter every guest that stayed in their hotel from the period of June 12th through July 15th, the day they closed. We went back again, since the incubation period is 2 weeks, we went back 2 weeks and then another 2 weeks, just kind of as a window of safety. When we were able to, they notified them by letter about the potential exposure to Legionella and to seek health care as appropriate. And at the same time, they also, in this letter, notified individuals that we, and in public health, wanted to assess through our epidemiologic study for case finding. We have an electronic survey that we developed in our SENS system that individuals could fill out and talk about if their symptoms, whether they were sick or not, whether they had laboratory diagnosis, and what activities they participated in the hotel itself. Sort of a standard outbreak questionnaire. But the hotel sent that out to everyone that was in the hotel for that, essentially that month's period of time. The next sort of large aspect of the investigation was the environmental investigation. And there's really kind of 2 parts to that. There's an initial assessment of the whole plumbing and water distribution system to look for areas of risk. Again, without testing yet, but just identifying what are the more likely areas of risk in this whole system, so that we can develop a sampling plan, and collect water samples from primarily these areas of risk, but that would represent the entire plumbing system in the facility. So the sampling plan is first. And then secondly, then you actually collect the samples and send them to the laboratory to try to determine whether there's presence of Legionella, in these areas of risk within this plumbing system, including the areas of the usual suspects as well, certainly, that we essentially asked them to shut down initially, and they agreed to. So the Legionella laboratory testing takes up to 2 weeks. So it's not an immediate, so in any case, much of this investigation is still ongoing, but tremendously complex when you think about these plumbing systems. So let's take a look at the EPI curve, the most recent EPI curve. I showed you the very initial one that we saw, but look at this guy. So this is nice too. So look at that big peak, in the beginning of July. So we do have some, what I'm showing here on this EPI curve is really we have 12 laboratory confirmed Legionella cases. They have lab confirmation, and we actually have 64 individuals that we consider to be probable cases. So they have had clinical symptoms consistent with Legionella, including physician or chest x-ray diagnosed pneumonia, and they were in the hotel 14 days prior to the onset of their illness. So they don't have lab confirmation, but they indeed, again, are considered to be probable cases as well. This is huge. This is a really, really large Legionella outbreak in a facility. Again, most of our outbreaks, again, may have 3 or 4 or 5 cases. So in this situation, again, is very consistent with what we consider a point source outbreak. It's not, cases spread out one at a time, trickling in over periods of months. They're tightly clustered over days and weeks, with a very high peak, kind of in the highest risk period in the beginning of July. And we got this information and found these individuals through responses to that electronic survey or our questionnaire, which we received well over almost 1,400 individuals replied back to that, and that's how we found all of these cases as well. So that was the EPI investigation, which is still ongoing, and the environmental investigation is also still ongoing. But I wanted to just sort of give you a little bit about the landscape of an environmental investigation and talk a little bit about how the sampling plan, again, is collected based on sort of areas of risk, and these samples are sent to an elite laboratory that is certified by CDC. And then, after the samples are collected, usually in these investigations, there's usually 2 rounds of what we call remediation. And the remediation is really just a way to try to ensure that any Legionella that might be present in these plumbing systems are again, eradicated, either by intense heating, or again, hyperchlorinating, or perhaps even doing some sort of plumbing engineering change if need be, so that areas of stagnated water are addressed so that it moves through easier. So again, these results are not available yet for this investigation, meaning we don't have environmental laboratory results yet. We are waiting, still awaiting on that as well. The hotel still does remain closed in order so that we can assess the results of the initial environmental testing. And then after that, again, the hotel has already remediated the plumbing system initially, once we see the initial testing results, we can see whether there's any other areas that need to be addressed. And then they go on with serial repeat environmental testing as well. So it goes on for a period of months, actually, in order to ensure that sort of these rounds of remediation to get the Legionella out of the system, if it's there, again, is successful and doesn't pose a risk in the future. So talking about these investigations really leads us to our general public health mantra and mission that they are preventable. These huge outbreaks like this ultimately can be preventable because they're very, very expensive, and again, the remediation is much harder than the prevention up front. And good water management systems are the way to go. So building owners, managers, including hotels, hospitals, healthcare facilities, can use this tool by CDC that really tells them exactly how to develop a water management program, according to industry standards, and really allows them to be able to maintain their water systems well, systemically, with appropriate, again, disinfection levels and appropriate management. And last but not least, my last slide is really another thing that often is an awareness reminder for healthcare providers. Whenever we have a large Legionella outbreak and we think about, it's important that clinicians often who are seeing patients that have pneumonia, remember to ask them about travel or stays or visits to healthcare facilities in the 2 weeks prior to their onset of illness, even if they don't, and consider Legionella as a potential in their differential. And in order to do that, to actually remember to order appropriate diagnostic testing for Legionella. We really want to encourage providers to order both culture and urine antigen testing in combination. It's really nice to have, you know, the rapid test result of the urine antigen test, but having the culture, having the actual isolate is really helpful in order to, again, use molecular testing to try to, again, unite that particular case patient perhaps to an outbreak that's ongoing even in another state as well, if it's not recognized yet, but it's really nice to have the isolate too. And also to remind providers to immediately report Legionella cases to us in public health so that we can indeed detect outbreaks and respond to them as we did, and be able to prevent, you know, further cases of Legionella as we move forward. And I want to thank you all for your very kind attention. More to come, I'm sure, about this particular outbreak, but I wanted to set the stage for very, very interesting outbreak, really the largest one ever in Georgia, largest one I've ever dealt with as well. So thank you all.
What will the criteria have to be for the hotel to reopen? What will have to occur?
So ultimately, in most situations that involve, again, hotel closure, again, which was a voluntary closure on their part, ultimately, they've already remediated the system, meaning they've gone through and done the remediation to the plumbing system. And so ultimately, we just want to be able to assess and work with them on whether, again, their initial test results just uncover some underlying issue that they haven't remediated. So again, whether it's a healthcare facility, hospital, or hotel, you know, again, they're not usually closed, you know, through all of the environmental testing because the ongoing risk is not there. Again, since they have, in most all situations, have remediated. Yes, Dr. Kern.
Sherry, I'd just like to thank you for the rapid response and the wisdom and courage that you showed. Had you not included the confirmed case, the suspect cases with the confirmed cases, you would have underestimated the extent of the epidemic, and that led a lot to rapid response and communications. I mean, you closed this hotel, you didn't close it. They closed the hotel within 3 days before the first case, and there were still 76 cases. So your rapid work and their response and cooperation resulted in saving lots and lots of people hospitalization and death. So thank you.
And I'd like to compliment you as well, first of all, for the great report, but also to your department and to my local health department. I live in Columbus, and I actually had 2 patients that came in with their letters from the hotel. They had stayed with their parents and came in and said that they needed to be tested for Legionnaire's disease. And I thought, well, that's not my usual what you're here for, but we'll figure it out. And I called the health department, and my local health department helped me make sure we got the right test on those children. So I think the system worked very well from top to bottom, and I think y'all are all to be complimented. So I wanted to do that.
Absolutely a large team effort. Our environmental health partners, our EPI partners, and of course the facility themselves as well.
I realize you're not through with the study, but given how complete it looks like it will be in the end, I would hope that you would be able to publish it where others could learn from this.
Yes, and again, and I completely concur, and I think, and we are looking forward to that as well. One of our primary missions is again, as part of our outbreaks, is again to be able to contribute to the body of scientific knowledge that indeed others can take this and learn, you know, some of our best practices or things that we learned as well. So I'm looking forward to that as well.
Thank you, Dr.
Thank you all.
Thank you.
Thanks.
We look forward to meeting you.
Madam Chair, and Commissioner Toomey, thank you for the opportunity to address you today. I'm introduce myself. I'm Carl Sotovier, and I have the privilege of serving as the director of one of Public Health's newest Office of Public Health Informatics. And so I'd like to take a few minutes of your time today to kind of share our vision for the work that we're doing. And usually when we talk about informatics, I get one of two responses. I either get the knowing nod, I get the sort of the sideways look about what exactly do you mean when you talk about informatics. And so I'd like to start out with what my version of it is, or my definition of it. And like anything, we want to take it apart and understand the components and parts and pieces of it. And informatics is really a combination of two words. The idea of information, having data, but data with context and meaning, and then automatic or automated, and doing something that requires limited human control. And so that's the basic definition that I'm working with. To dig into that a little bit more, I'm going to use some pictures to kind of illustrate what I'm talking about. Starting in the upper left of the slide, what we see here is basically an idea, right? But an idea is just that. It can't become information until it gets communicated. And so as we move to the center of the slide, we see a common form of communication, face-to-face communication. And the nice thing about face-to-face communication, it allows a really rapid back and forth exchange of ideas. It's probably the most single complete form of communication that we engage in. But there are certainly other ways to do it, and we move over to the top right, and we'll talk about this idea of having one person provide information to many people, kind of like myself standing in front of you. And we think about this as giving a presentation, or maybe you can call it storytelling. And it's certainly a long-standing and old form of communication, but it has problems too. It primarily relies on speech, and speech is ephemeral. It doesn't last in our minds. And so we move down to the lower left corner of the slide. We think about ways that humans have tried to deal with that problem. And some of the oldest recorded communications that we have are found in the form of cave drawings. There's a cave in Chauvet, France. The drawings in there are from 30,000 BC, which you can imagine. It's quite a long time ago. But there's problems with drawings, right? Sometimes the message is not as clear, and furthermore, if you draw it on the wall of a cave, it's not really portable. You can't move it around. And so humans are innovative. We've come up with ways to solve those problems. We invented writing. We invented alphabets to sort of condense ideas and words and symbols to make that move. And so we're going to fast forward a long way into the future. We look at this slide, and we see, we have so many different opportunities today in the modern world to engage in communication, everything from telephone to television, radio, film, cell phones, fax machines. And of course, sort of at the center of this is computer and information technology. And so thinking about the ways in which we exchange information. But there's a pattern in this particular slide, and sort of what you see here is underlying all of this is the presence of machines. And that sort of brings us back to this idea of working with information and machines. And so when I talk about informatics, what I'm really talking about is just understanding how to help us communicate with each other in informative ways, and using machines in an efficient and effective way to achieve that goal. And so why is this relevant to public health? Well, by better understanding the needs of public health, the information needs, and how to meet those, we can advance the mission of public health. And we can do that in a more efficient and effective way based on how we use technology. And so to look at that particular question for public health is really the reason or the impetus for developing the Office of Public Health Informatics. And so OPHI, we position ourselves basically as the advocates for the information and the needs of the department. And our mission is to ensure that the technology that we use and the business processes that we put in place are well aligned with each other, and that they support each other to be sure that we're effective in our use of the information that we generate. We have three primary areas of focus. One that's key, and one that historically public health has had some challenges with, is really this idea of interoperability. When we talk about interoperability, we're really looking at the places that exist in between our data systems, and thinking about how do we make sure that those data systems can communicate with each other effectively and efficiently. And so looking at standards-based data exchange and bringing interconnectedness to make the way that we use data in public health more efficient. The second area of focus is on business intelligence and analytics. The way that we analyze the data and the methods and techniques that we use, our goal is really to provide support to the experts in that arena to make sure that the environments and the computing systems are there to to help drive that analysis and better perform and more efficiently perform those analysis. And so in order to, bring the ability to make better decisions. And then the third area really is around knowledge management. And it's the idea that we bring a methods-based or disciplined approach to how we understand where our data comes from, what the provenance and lineage of that data is, how that information flows through the organization, and capturing that in a way that we can share that and that remains with the data, because data by itself is very difficult to understand unless you know how it was generated, where it came from, and what part of the process it was a part of. And so, to give some more specific examples about each of these three areas, OPHI, we really have our strategic focus on looking across all of the areas of public health. We're not just focused on specific programs. And so if we look at this slide, this sort of represents the scope of work that public health does. We have all the various activities between, such as providing health services, performing disease surveillance, making policy, performing lab tests. And we think of that as the work of public health. So let's take this example and consider the idea of interoperability and how it plays out here. So here we have some work that's being done, and as a part of that work, we're generating public health data. Often cases, a lot of our public health workers are the primary source or primary input of that data. They use a keyboard and put that data into a computer system. And there's often no way around that, but the reality is that as we add more systems and more workers, what we see is we start to see duplication in effort. We see this system needs this piece of data over here, so it's keyed in here. Another system needs data over there, and it's keyed in again. And there's a lot of duplicitous data entry and additional effort. So the goal of interoperability is really to take a look at that and say, what can we do from a systems perspective to make the systems talk to each other? And so in this example, we see that instead of keying data into systems A and B or C and B, we now have systems A, B, and C talking to each other, and we only have to input it once. And that's really fundamentally the goal of what we're looking at in the area of interoperability. In the realm of analytics, let's turn this equation around and look at it from a different perspective. Instead of generating data, perhaps we as a public health worker have an information need that we're trying to meet. Oftentimes when we go to do that, the same systems that we put data in, we now have to reach across all three of those systems and grab the data that's there and pull that back, and often we have to add to that. We have to do some work with that data between those systems, which again works if it's a small situation, but as you add workers and multiple systems, it becomes a lot more complex. So the other area that we're working on is to support and develop a shared analytics platform for public health, looking to develop a place where we can bring data sets in a consistent way, leveraging both the automation that's available to us from the data systems, bring that into a shared platform where public health workers can access that data and spend less time trying to obtain the data and manipulate it, and more time trying to do the analysis work that is so critical to the job that we're doing. And then this third idea of knowledge management. As we add more systems, even if with a shared analytics platform, we still start to see a huge increase in complexity between the number of users and the number of systems that are out there. And so the third piece that we're working on is adding to this platform this idea of a data catalog, bringing a locus where public health workers can go to access to understand what are the suite of data sets that are available to public health to make decisions and to work with. Making sure that the data sets are, described. It's, things like understanding, where did the data come from? How often is it updated? What type of data is it? What are the privacy and legal protections around the data? Even potentially providing it as a means to access the data in a controlled way. I mean, as the complexity and interoperability and analytics expands, the catalog is really going to become an essential piece for us to keep track of and understand the data sets that we have. And so that's sort of our vision and our strategic mission of informatics. And now I'd like to just kind of share some of the specific projects that we've been working on. The office was formed, so we're just shy of a year old. We were formed in last September. And since then, we've had the opportunity to participate in a number of activities. Probably the principal project that we're working on, particularly in the area of interoperability, is, we call it our lab interface project. But most of the health departments within Georgia still order lab tests from the public health lab on paper. And the reality is that we have clinical information systems at work in the health departments, but the lab orders themselves have to be written out, the papers attached to the specimen, and then shipped to our public health lab for testing. We have developed a project, and we're working through this. We have three health districts now that are doing this electronically directly from their clinical information system. It's the Gwinnett Health District, the Cobb Health District, and the Rome Health District. And we are working on, throughout the rest of this year and into early next year, bringing the additional health districts in the state on board with this project. And I mean, the benefits are already immediate. We're seeing much faster turnaround times on testing, much more accurate data entry, particularly in the realm of billing and reimbursement for lab procedures. And so that's, the informatics team is heavily involved in working through that. In the area of analytics, we are actively working on developing the shared analytics platform. We're fortunate to have some funding from the opioid grant that will allow us to sort of kickstart the environment, and we hope to be able to bring together a lot of the data sets that are supporting our response to the opioid epidemic into this environment, and then build on that to broaden it for the more general public health. Some of the other things that we've been involved in, we had an opportunity to collaborate with the Georgia Institute of Technology. They have a master's program in operation research, and so we basically sponsored or provided the course material for one of their courses, where we brought them in and connected them with epidemiology. We looked at our process of interviewing for salmonella cases, and these students brought in mathematical models and a perspective on process engineering that was somewhat unique and different in terms of how do we optimize the way in which we handle, since we don't have the resources at present to interview every single case of salmonella, how do we prioritize and optimize the way in which we approach that process. And so we were able to provide the course material for their work, and they were able to provide us some concrete suggestions and results that were based in their data analyses of the work that we're doing. So it's an interesting project to be a part of. And then in the area of knowledge management, the data catalog is probably our primary initiative. We're undertaking, developing a process by which we can go and catalog the data sets and gather the data and information, or gather the metadata about the data, so that we can then publish that and make that available to the department. And our long-term goal is to make that not only available to the public health community internally, but also to our partners, the academic institutions, and really have a robust mechanism by which we can build awareness of all of the various data sets that are available, and to hopefully drive more focused research and work. And with that, take any questions.
Thank you.
I have a question. Thank you for the presentation. The data you're generating is really very valuable. I know that we in the state now have a number of academic public health programs, and I think you're going to see a demand from those groups to use that data. And we in public health are very good at giving things away, and I would just suggest that you have a good handle on what the costs are for them to receive that data, and not be shy about, in a reasonable way, charging them for that data. Emory can certainly.
Well noted. Indeed. I think that
At UGA we can't, but Emory can.
fair enough. I appreciate that.
Good point.
That's their premise.
Any other questions?
Just a comment, having worked on some projects regarding trying to access data through GHIN and the Medicaid system, and what you mentioned in the very last of your bullet points is matching the correct patient data is key. I mean, if you don't get the right patient, then you don't get the right data. And additionally, if you don't have data being input in the same format, it never comes out exactly the way you want it to. So I can't, as you know, stress enough how important that is, although it sounds ridiculously simple. It's the most complicated part of all of it. And it's just so important as we try to be more quality for patients and provide the correct information for them. If we don't have the data, but just because we don't have their name right, or we don't have their diagnosis or all their medicines or all their immunizations just exactly right, it can be catastrophic. So you're certainly have a monumental task, but good luck. We put a man on the moon, I think we'll be able to do this.
I agree, those sometimes the small ones are harder, but absolutely, I think that's, focusing on that activity, and, we have a lot of different tools available, so, GHIN certainly provides that capability, and we also have, the state of Georgia has a master patient index through the Gateway Initiative, and so thinking about how do we as public health leverage that, but then, once we do that matching, making sure that we're doing it efficiently for all programs, rather than what happens now, often is individual programs will do that matching repeatedly, and so thinking about a more broad way to make it more efficient is really our goal.
The 3 counties that are using the lab orders, the electronic lab orders, what platform are they using? What?
So the clinical information system is Visual Health Net, so it's the Harris Computing, and that's in the health department, and then the test orders are received and processed by the Apollo LIMS system, which is the laboratory information management system that GPHL uses primarily for the main core of their testing in microbiology and virology and so forth.
And I would say, I don't know how to say this, but look at the things that are working great, that are already interoperable. I mean, I think GRIT started off with a rough start way back when, but now it works. Newborn state screening started off with a, and has just grown astronomically, and it works. If we could mirror some of those, because I see other things that just, in all these systems you're talking about, you can find those 2 sets of data pretty quickly on patients, but some of the other ones don't work quite as efficiently.
True, and that is our goal, is to really bring the expertise in integrating these systems, or interoperating is the more appropriate word. And around newborn screening, as an example, there is an effort that we have ongoing where we have the equation between, say, the SENS system and the LIMS system part of it, but the provider part of it, the hospitals are still primarily ordering those on paper on the heel stick cards and driving that to an electronic process. We're in partnership with Piedmont Healthcare working on enabling electronic ordering of specimens from, or the newborn screening test orders electronically from Piedmont to turn that data capture around much faster with a lot less paper and a lot less manual processes. So we continue to innovate on that.
We look forward to hearing more. Thank you.
I look forward to providing more. Thank you so much.
Any other comments? Commissioner? Well, thank you. We stand adjourned. We will meet again in September with our new slate of officers. Thank you for being here. Thank you for the presenters. May we have a motion to adjourn? All in favor?